Thank you very much, everybody, for joining us. This is New Reality with our semi-regular Zoom side chats with opinion leaders and others around the industry. And for this special one, our last New Reality with interview of 2020. Thank goodness it's the end of 2020, I think we can all say. But this is a special one because it's absolutely not an industry person that we've invited and who's accepted our invitation to come along and talk to me and to talk to everybody else today. So his name is Dr. Erik Lium. He's the Chief Commercial Innovation Officer for the Mount Sinai Health System based in New York City. So Erik, thank you very much for joining us on PhocusWire and New Reality with this week.
Pleasure to be here. Thank you.
Okay. As much as I would actually like to have a chat with a doctor about my ongoing eye infection, we're actually going to talk something of far more interesting and important, given the state of where we are in 2020. And that's lots of things with around the coronavirus pandemic, its impact on healthcare, and more importantly for our audience, around the implications of some of the things that you're involved in, that you have opinions on with the recovery of the travel industry and how these things kind of are sitting in a melting pot and what kind of comes out the other side. So we've got you for about half an hour or so. And again, we're very grateful. But if it's okay with you, I'd like to dive in. And first of all, Erik, can you just give the audience here, because I would imagine you, I mean, you were a stranger to me until about a week ago, but I would assume you're probably a stranger to everybody that's tuning in, what you do at Mount Sinai and some of the things that you've been doing over the course of the last 10 months, if you can.
Yeah, sure. I'm happy to describe. So by training, I'm a scientist, so I'm not a medical doctor. But as you said, I do serve as the Chief Commercial Innovation Officer for the Mount Sinai Health System. So, within our system, what we've been doing since the pandemic really hit New York was obviously tremendous amount of clinical care, but also working on solutions to try to address the pandemic. One of the things that we did very early on was to develop a test, a diagnostic within our clinical laboratories that would allow us to detect the level or measure the level of antibodies to the virus that individuals had. And that was used for actually identifying individuals who could donate convalescent plasma or their plasma after being infected, because that plasma is rich in antibodies. So the goal there is to be able to test and see who has high levels of antibodies, and then for that convalescent plasma to be used in other patients who are very ill or who have contracted the disease to help them recover. And so, then we've actually recognized an opportunity to advance that further. So we've actually developed a corporation around that and have done some partnering to develop a commercial kit test that has received CE mark approval and an FDA EUA. So those are some of the things that we've done in terms of actually developing tools that can be helpful. Obviously, again, we've done a tremendous amount of work on the clinical side in terms of treating patients as well. And as an institution are participating in a significant number of clinical trials.
So this is the 15th of December. We're right at the end of this terrible year for everybody, not least the industry that we're talking to now. But can you give us a sense of where we are, an overview of where we are in December with regards to testing, vaccines, your particular antibody testing and things like that, and the development of those? And, as we look into next year, where are we right here, right now?
Yeah, so in terms of what I think of testing for infection and testing for immunity or an immune response. And so when you're testing for infection, you're testing for the presence of the virus. And there's a number of ways to do that. You may have heard of what's called PCR testing. It's a type of chemical reaction that is used. Those tests are generally deemed to be quite quite good, accurate. They take longer. There's also antigen testing, which tends to be a faster type of, more rapid type of test. And but both of those fall into, again, what we would think of as testing for the virus or testing for an infection. And that type of testing is something that measures the presence or absence of virus at a moment in time. And so what we see now, and what would certainly be relevant from a travel perspective, schools, many things that we do in everyday life, is that if an individual is tested at a moment in time for the virus, that individual could be infected and just have that they could get infected in the morning. They could be tested at noon for the virus. They'd be negative, but they would be positive a day or two later. And so again, virus testing is testing at a moment in time.
Eric, apologies for interrupting. I'm curious. What is the kind of the latency between people becoming infected and the first signs that they show? Is there an average, or has there been any work or any science carried out to establish that length of time?
The information certainly that I've read, I haven't looked at this recently, but is that the time frame for an individual, kind of the incubation time, or the time from, say, exposure to symptoms, has been described in 1, 2 to 5 days range. The period that an individual's asked to quarantine originally was 14 days roughly. It's being reduced down to, I believe, 10 days. And that reflects the fact that we're getting more, we understand more now about the time frame for an individual to go from exposure to symptoms and a real infection. But I think the average, again, this isn't something that I've looked at recently, is in the kind of week range, 2 to 5 days, in that range. Right. If you were to go online and just look up, there's a fair amount of information from different public health agencies on these types of estimates.
Yeah. Sorry, I interrupted you when you were saying that someone could be infected at lunchtime, in the morning, and then a test would be taken at lunchtime, and it would obviously show negative. So how does that all kind of carry on from there?
Yeah, so all I was pointing out is that, when we think about how you open economies, how you really achieve a broader kind of practical understanding of safety or protection, whatever the word is that you'd like to choose. When you're testing for virus, you're testing at a moment in time. So again, I use the scenario, a person could be infected in the morning, they could get a test a couple hours later, and the test could, be negative. But then they would obviously progress and be positive within 2, 3, 4 days, what have you. Mm-hmm. At the same time, an individual could get tested in the morning and be negative, and could get infected that afternoon, and then show up in terms of symptoms would start to become apparent over a period of days. But we also know that there's a population that is asymptomatic, so they do have infection, but they don't have symptoms, and so that's obviously a very complicated element of this virus, of this disease, when you think about it from a public health perspective of being able to control it, because you again have individuals that may have no symptoms that are obviously spreading virus. In terms of, you asked about testing, the other type of testing would be testing that looks at whether an individual is potentially protected. So does an individual have an immune response to the virus? And obviously that there's going to be a significant number of individuals soon as vaccine programs roll out. The vaccines are specifically designed to elicit an immune response to a protein in the virus that is critical for the virus to infect cells or infect a person, to create an infection. And that protein is called the spike protein.
Yeah.
And so an individual who receives a vaccine, we've heard different rates that 90% of individuals are protected, what have you. Whatever the relative rate is for the different vaccines that become approved, right? That's one way to develop antibodies to this key component of the virus. And those antibodies can be measured. Another way to develop antibodies to those key components of the virus is to have an infection and have recovered. And so when we think about testing in terms of antibodies, or ultimately for protection, or what you might call immunity, that can apply to individuals that have been infected, and eventually will have an understanding of the level of antibody that's required, as well as then how long that antibody lasts for. But unlike virus testing, which is a moment in time, testing an individual for antibodies is something that would be done on a much less frequent basis. So say once every 3 months or something like that, once every 6 months. So from an operational perspective, would be much more practical.
Can you give us a kind of a basic science overview of the work that you've been doing around antibody testing and why it's important, and then we can kind of go from there and start talking about the implications of that?
Sure. So a number of scientists, clinical scientists and basic scientists at Mount Sinai have been studying essentially the antibody levels in individuals following infection. And obviously, we've all heard in the news, there's a lot of information about what happens after someone recovers from infection. There was also a lot of information about antibody tests back in, let's say, kind of February, March, April of 2020, where it was found that there was concerns regarding the accuracy.
Yeah.
And I think so now we're in a time frame where kind of a next generation of antibody testing is being developed. And these are tests that actually, instead of just saying, yes, you have antibodies, or no, you don't have antibodies, these actually say, well, how much do you have? So do you, and how much? So a number of studies are being conducted worldwide. Certainly Mount Sinai is participating in some of them. And these are to look at antibody levels, particularly antibodies to this key component of the virus, the spike protein, and watching over time. So for example, taking an individual that has recovered, measuring their antibodies, let's say, 2 to 3 weeks after they've recovered, or after the symptoms have gone away, looking at the level, and then looking every other week or every other month. I said every other week, or say monthly after that. And so one of the studies that's been done actually, or that's being conducted at Mount Sinai and other sites in the United States, is looking at healthcare workers, both workers that were exposed and recovered, and those that have not been exposed. So we think of those as naive. They are naive from the perspective of having seen the virus from an infection perspective. They wouldn't have an immune response to it. So following them, I think it's roughly every 2 weeks, and having them come back and measuring, checking, is there virus? Can we detect any virus? And then what is the antibody levels that they have? And what we've found in a recent study that was published in Science magazine, and this was looking at over a 5-month period, because that was that's the amount of time we had so far. Yeah. We're continuing to do, the scientists and clinicians are continuing to pursue these studies, right? 6 months, 7 months, 8 months, as we move further and further away from when the pandemic began. And what we've seen again is that the majority of individuals post-infection develop a medium, what we're calling medium to high level of antibodies.
Yep.
and that the majority of those individuals maintain those levels. And again, these are antibodies to the spike protein. That's all we're measuring is
Yep.
Antibodies to the spike protein. And so that's actually that's a great finding. But we have to continue following individuals over time so that we know how long these immune responses will last. And I tend to use the word durability as a general word related to the response of how durable is it, how long does it last.
May I ask? These are ongoing tests, so and it's what
Studies.
X number of studies. I beg your pardon. And it's only X number of months that these have been in the field, as it were. But are you able to give a sense of what you expect to happen? I know it's, you can't, you've been monitoring things and you said there's a medium to high level of antibodies after X number of months, but which obviously is good. But do you have a sense as to how that might change?
Well, again, some of this has been published already. And so what we've seen is that individuals who don't have any immune response, who have not had an infection, they haven't in theory been infected by the virus. In these kinds of studies, there have been individuals, even though they are social distancing, they are wearing masks, they're taking precautions, that have become infected. And that's what you would expect, right? These are individuals who haven't been infected and they become infected over a period of time, because there's many individuals participating in these studies. And then what we can also say is that we're not seeing for individuals with medium to higher levels of antibodies as a result of infection, we're not seeing any additional disease in them. We're not seeing any reinfection in them.
Right.
But again, I want to emphasize that it's still relatively early, and we're working on getting to the point where we have an understanding of, again, how durable is this? But every month that goes by that individuals maintain these responses is one more month of durability where we can say, okay, whether it's 90% or 80% or 70%, whatever it is, you can say, well, that this number or this percentage of the population maintains these levels of response over time. And so that's a very important measure. And then also what's very important is that because these studies have a large number of individuals, in theory, at some point, you may identify that. So if for those who have antibodies level of, let's just say X and up, you don't see any reinfection. And X and below, right, you start to see some reinfection. That's in theory, I'm saying, right? I'm not actually reporting results here. But this isn't something that's new. This is the kind of science that has been done for decades to determine what is the level of antibody that is required to be deemed protected or immune.
Right.
Just like if you go to work in, certainly where I'm familiar with is if you go to work in the Mount Sinai Health System, they test you to actually determine, what are your antibody levels for common diseases, right? That most of us have all been vaccinated for, right? And there's a number for each of those. And that number has been determined over many years of, okay, this is the level. And the same is being worked on for COVID-19 or SARS-CoV-2. So if you look at some of the data that was released recently in the related to, say, the vaccines that are being approved, what some of the data there indicates is that you can literally see in their clinical trials where individuals are vaccinated, and if you're looking at the rate of infection, some are vaccinated and some receive placebo, right? And the curve of those that are vaccinated levels off, right? They in terms of getting infection, right? They get vaccinated, it goes up a little bit in kind of in parallel with people that got the placebo. And then people that are getting placebo, the curve continues to go up. But for those who got the actual vaccine, it flattens off, right?
Okay.
And you see those diverge. And so what that tells you is that the vaccination is causing, right, those people that receive the actual vaccination are developing protection. And there's also data in those reports on the actual levels of antibodies that were detected as well. So my point is there's a lot of studies going on. There's a lot of work to actually determine what a level of protection is going to be, as well as the durability, whether it be from vaccination or from infection.
One of the things that I thought was very interesting when you and I spoke last week, Erik, was you were talking about the tipping point in a population with regards to infections, immunity, antibodies, and things like that. Just talk us through what the tipping point is and kind of where we are, like where you are in the US. I mean, where is the US, do you sense, around tipping points and things like that? And others that are tuning in from other countries can kind of look at their own data and kind of figure things out.
Yeah, and so what we were talking about is that this is what we expect to occur based on what's currently happening. You have a pandemic when it starts. You have infections increasing very rapidly, and you have testing for those infections increasing very, very rapidly. And that at some point, and in our case, right now, what we're seeing in many locations in the world is very, very high rates of infection. And the more people who are infected and that develop an immune response, and what we're seeing again in the studies is that it appears that there's protection in there, right? In individuals that have recovered. Again, we're not making any specific statements on exactly what that is yet, but we're seeing, right? If there was no protection, you'd be seeing very high rates of reinfection, and we just don't see that, right? That's not what we're seeing. So you have a very, very significant increase in the number of infections. We've got to the point now where you start to argue that the rate of infection is going to is starting to mean that there's a significant percentage of the population that has seen this virus, recovered, and developed some kind of immune response. Then you layer in vaccination, and vaccination essentially accelerates in a population, it accelerates your progression toward what people call herd immunity, right? Herd immunity just means a point at which in a population, a sufficient number of that population, percentage of that population is protected and has immunity, that you start to see infections dropping precipitously because most people are protected, right? And it's a complicated science. There's a lot of different information on what the actual numbers of, when you achieve herd. But what we do think is going to happen is that we're seeing massive testing for infection, for virus right now, because we have very, very high rates of infection. But what's going to happen when you bring in the vaccination, plus added on to these very high rates of infection, is that you're going to shift to monitoring and or testing for immunity or for protection. Again, kind of emphasizing that there's a lot of studies being done to understand that, and the vaccines that are being approved in their studies demonstrate individuals become protected.
Yeah.
But what we would see is we believe there's a transition toward really immune monitoring, understanding immunity, because of the number of individuals in a population that will have seen the virus and will develop an immune response, or will have been vaccinated and will have antibodies against this key component of the virus, the spike protein.
So we've gone through a lot of the science and the medicine of how all this has kind of played out so far, and I'm kind of keen to kind of dive into what it all means for the industry that you and I are talking to today. And, one of the things that we did discuss last week, Eric, was around, imposing testing for immunity, whether you're going to fly or whether you're going to get on a cruise and things like that. And one of the elements of that we talked about was just the feasibility of that level of testing when you are testing for immunity. There's been lots of talk in our industry over the last 10 months about, well, you can test somebody before they get on a plane, which I think has some big question marks around it, or the same if you're about to get on a ship. I mean, just to kind of start things off, give us your kind of take on the feasibility of imposing mass testing for immunity rather than infection on an industry that, frankly, is desperate to get going again.
Yeah, so testing, I guess what I would say is that, we would assume there's going to be various tests that are available, so testing platforms from different companies, and that those tests will largely be run in laboratories that are certified to run those tests. So in the United States, for example, a CLIA certified laboratory, in other parts of the world, similar types of certification. And these tests can be, they can be automated in many ways. They can be run at mass scale. One of the challenges that does exist, though, is the type of sample that's required. And in many, I have to say at the moment, I believe they all require a blood draw. Please don't quote me on that, but I know certainly our test, the Kantaro Biosciences test, requires a blood draw. And then it requires the test to be performed in a clinical laboratory. There's obviously many, many, many clinical laboratories across the world. They're in hospitals, there's large companies that run clinical labs. And so I think there's an opportunity to actually do these types of tests at scale. Currently, those who receive a vaccine, I believe, are going to be deemed protected. They may, an individual may say, well, I had the vaccine, I'm curious, I want to know, did it have the proper effect? Did it have the right effect for me? And one of the ways, really the way to determine that, is to get one of these kind of next generation antibody tests that allow you to say, well, yes, it did, and how much did it? Did it, what level of antibody do you have against the spike protein? So I do think it's feasible. I do think that it requires having the tests run at in many laboratories. Now, the advantage that I was kind of commenting on earlier, though, is that, as we talked about, for virus testing, you could say I could test an individual every single day, because it's testing in a moment of time. Whereas when you're testing for antibodies post-infection, certainly post-vaccination, the amount of time that we're seeing is that, so most individuals in our studies post-infection, that they achieve a level of antibody and they kind of maintain that level. And again, we've published data out 5 months. So in that kind of a situation, you start thinking about, well, how often do I have to test? Is it once every 3 months, 6 months? The further we go, the more data that we have, and this could be data generated internationally, right? The more data that we have showing that spike antibodies, anti-spike antibodies following infection stay high, and of course also post-vaccination stay high, then you could get to the point where, maybe I check once a year, maybe I, and at some point, maybe I don't have to check again.
Okay. Again, going back to the levels, it's levels of immunity. Now, my sense is that a travel company or an airport is going to want something that's very black and white. You are either immune or you are not. and whether this, whether this medium to high level of immunity, you get into gray areas, which is the world that you're living in, because it's testing and it's variations of an immune response. But from a, dare I say, a practical perspective, in a from companies, they're going to want either one thing or the other. Or do you think there is going to be an acceptance that there are varying degrees of immunity, and then organizations or regulators need to decide whether, okay, well, medium to high is okay, low to medium is perhaps not okay?
So ultimately, public health officials have to decide. If I understood your question correctly, public health officials have to decide what, say, the level of antibodies is to be deemed protected or immune. Again, the studies that we're doing are specifically designed to begin to understand that. And over time, if you look at individuals that have been infected, they have antibodies, the response remains durable. In other words, they continue to have those antibodies, and they don't get infected, right? Then you begin to have more and more assurance that on a population basis, there's protection. And ultimately, you'll end up with a specific number. So knowing your number, I have X amount of antibody, will be important at some point.
Okay.
Now,
sorry, go ahead.
No, please go ahead.
I was going to say, we've got a question from the audience. If I can, I no sense whether you're going to be able to answer it or not, but it's coming from the audiences. And businesses in the travel and tourism industry have benefited from growth in global mobility of individuals. They've also been greatly impacted by that mobility ceasing due to the public health risks of coronavirus, right? Do businesses in the travel industry have a corporate responsibility to support scientific research on diseases or potential future responses to them? Our audience members paraphrased the whole thing for us at the end, but I think the context was good. Should research in global health be part of a corporate social responsibility portfolio of a travel and tourism business?
This is it's a very fascinating question. I can say that I've participated in a number of conversations over the last 6, 7, 8 months about how do we prepare for the future? How do we prepare so that if this was to happen again, or something like this, that we would be ready to respond much more quickly?
Yep.
I think that, and I should say, in those conversations, there have been concepts of creating funds, or creating approaches where industries to help support these kinds of activities. So I guess when you say, should you, my inclination is, I think we should all understand that this could happen, right? These kinds of viruses can emerge. Yep. What there are infectious diseases where these kinds of situations can happen again. We've heard about the flu in 1918, for example, right? So we have prior examples. I think it would be wise to certainly take steps to fund specific activities so that we are prepared in the future if something like this was going to occur. And I'm sure there's very, very divergent opinions on, well, what does it mean to truly be prepared? But some of the things that we're going to be going through now will certainly help in terms of, kind of, how do you monitor whether an individual's been vaccinated, or ultimately if they're protected, or what have you. And so some of those kinds of tools are being built now and would be available us going forward. But I think about also, what are the scientific and clinical tools that would be potentially, that you could develop, that would be readily available, or even testing capacity that you might want to have readily available if something like this was to occur.
Talking of testing capacity, Erik, I mean, do you have a kind of an opinion, or some kind of idea how, let's just say, a cruise operation might start kind of thinking about testing and all those kind of again, it's back to the practicalities of this, which, the science is complicated, the practical part of it is complex. So you've got these two kind of forces coming together, and the cruise industry, which you know I think some would argue has not come out of this at all well over the last 11 months or so, is right in the kind of the sweet spot of where these things potentially have the opportunity to get out of control again. So if you were advising, or give us your opinion on how a cruise line, for example, might be able to think about what we've been talking about.
Certainly in the context of the current situation,
Yeah.
I think that, and I can provide my opinion. Like if it was me and I was responsible for making these types of decisions, or the things that you're alluding to for in the cruising industry, deciding what is necessary to ensure that there is safety in a cruise, right? And so to me, safety means the lack of infection. And what we know, we've talked a lot about testing today, is that unfortunately with virus testing, what we see is that even when people are tested, again, you can see infection emerge. And then, of course, we've also seen that there's been, I think, a couple challenges related to false positives as well.
Yeah.
But this is where I think, making decisions and again, following public health guidelines is going to be critical. But making decisions on, do individuals on a cruise need to demonstrate they've been vaccinated, or they have another level, another approach to being protected? And what does that look like? So one way would be to say, okay, do you have the levels of antibodies that ultimately we understand are protective or not? And that would be done through a simple antibody test, generally, through, when I say simple, determining the level of antibodies in an individual. It may be that public health professionals ultimately say, if you've been vaccinated, that's enough. But if you haven't, then you have to in some other way demonstrate that you are protected, that you have the level of immunity that ultimately public health officials will accept. I mean, I think about this to some degree. I remember as a child going to school and having a little book, and in that little book, my mother always had it, right? In the little book, my doctors had kind of signed off on all the different vaccinations that I had, and the dates and the boosters and what have you. So I don't think this isn't a new concept.
No.
Right? We've all dealt with this in some way or another. Certainly most have, as children going to school and verifying that we were vaccinated for common diseases. It's just that we're doing this for a new disease on a global scale now. But again, for me, if I was making decisions for the cruise industry, I'd be following public health guidelines very carefully, and I would be focusing on who is protected or immune based on what the public health guidelines are. Have they been vaccinated? Is that sufficient? If they haven't been vaccinated, what are their antibody levels? Do those antibody levels meet the defined criteria for being deemed protected or not? And again, I think, this is my opinion, I think where we're going to get to is, at least based on the studies at Mount Sinai, that we're going to see that the majority of individuals have a durable immune response for a significant amount of time. And again, whether you end up saying, okay, you need to have an antibody test every 6 months or every year, or it goes to every 2 years, right? That's going to become clear over the next months, right? And I actually think it's pretty practical to have a process where, you have to demonstrate A, B, or C, and that's a criteria for ensuring the safety of the passengers on a cruise ship. or on a flight or what have you. Now, at the same time, I don't want to, I feel like I should say, as more and more individuals are vaccinated, more and more individuals have what is ultimately deemed as the being immune or protected, then your risk goes down dramatically as well.
Yeah.
Right. So,
is there any? I mean, we've talked a lot there about the cruise
and what
sector.
I mean, I should say, just the risk of an infection goes down dramatically.
Yes, and we talked a lot about the cruise sector. Is it that? Would you say that it's the same for aviation and airports? Or do they need to think about things slightly differently? And maybe this is just my naivety showing a little bit here. I mean, everyone's on a cruise; they're in a confined space for weeks often, or at least a number of days, whereas an airport and an airline, you are within enclosed space with somebody for a much shorter period of time. Okay, maybe sometimes 12 hours, but you know what I mean. The circumstances and the context are different. Do you think they should be thought of differently with relation to what we've been discussing, or is it the same process that you think they should go through?
They're very different environments, but
Yeah.
In a plane, you're in a cabin, you're in a confined space. It's less time, but it's confined. You're arguably closer to if you have someone saying sitting right next to you, right? You're closer to a stranger than necessarily you might necessarily be on a cruise in terms of on an ongoing for a period of, say, hours. I don't think that the criteria would be different, because again, it's really about wanting to ensure that the vast majority of individuals are protected and are immune and through some measure. And ultimately, 2-3 years down the road, where, right, in theory, we would all predict now we should have herd immunity. There's no question, right? We've got vaccines. There's going to be multiple types of vaccines. You've also got people that were infected and recovered, and will have lots of data over a significant amount of time about those individuals. So I think there you'll have it'll be pretty clear. But I don't think the criteria would be particularly different. For example, if you were to say, would it be okay just to do virus testing for the time being for airlines? I myself would not agree with that. I think that, right now we're using that because it's one of the best things we can do. But as we move forward, again, shifting into demonstration that an individual's been vaccinated or that they have another source of protection, I think is going to be the way you want to go.
Okay. I promised you that we would be done after 45 minutes because you're a busy guy and we're right up against time. So if anyone is interested in finding out about the work that Erik and his colleagues have been doing, there is a lot more information on mountsinai.org if you want to go and look there. And there's lots of things that they've been publishing around everything that we've been talking about. Erik, thank you very much for joining us. I've never said this to any person I've ever interviewed from the industry, but thank you very much for all the work that you do. We really do appreciate it. And in the context of today, thank you very much for joining us on New Reality With. We're happy holidays, as you say, in the US, and a very, hopefully, a much better 2021 than this year. Thanks ever so much for joining us.
Yeah, well, thank you for having me. Again, as we discussed, if people have questions, I'm happy to try to get answers for them, and would be happy to chat with people.
Okay, great. Thanks ever so much, and we'll see you
Thank
again.
you. Take care. Bye-bye.